Hi, I'm Autumn Sanderson, and this is video 1 for Respiratory 2480 on pulmonary function testing. So, what is a pulmonary function test? This is a series of tests that's going to include things like a spirometry, a body plasmography, which is also known as a body box, a nitrogen washout, and a DLCO or diffusing capacity. And these series of tests are going to measure how well a patient's lungs are working. They can assess things like our lung volumes and capacities, our patient's flow rates, and gas exchange. And just as a refresher for myself and the purpose of this video, we have a display here of our volumes. So PFTs provide a lot of very great information, especially when we're considering patients that may or may not have different sorts of respiratory diseases. It's really crucial for diagnosing and managing those, as well as monitoring disease progression. We want to see if we're getting worse, if we're getting better. And that also goes hand in hand with evaluating treatment. Not every patient is the same, so some patients might need a different course of treatment than others, but PFTs can provide a lot of great information letting us know if the treatment is working. For pre-surgical assessment, so a lot of patients, their doctors will have them get PFTs before surgery so they can see how well their lung function is. Even healthy patients, especially if you're going in for a procedure, let's just say a lobectomy, where you're going to be cutting out part of a patient's lung, that pre-surgical PFT will be very crucial. And I'm sure following up after surgery, the doctor will want more PFTs, and then you have something to compare to. It's also really great. PFTs provide a good insight to a patient's overall health in regards to their occupational and environmental exposure. So, if you're somebody that works in an environment with a lot of smoke or chemicals, or maybe you're around people that smoke a lot, PFTs can provide information on whether or not your lungs have been affected by that. They also provide the following information, and this is going to tell us how healthy the lungs are or the patient's respiratory health. So we looked at that slide a few slides back. Here we have our volumes. So our IRV, total volume, our ERV, and our residual volume. PFTs are going to give us that information. They're going to tell us how much air is in the lungs. That is what our lung volumes are. How much air can our lungs hold? Flow rates can also be determined based on PFT data, and this tells us how well air moves in and out of the lungs. Gas exchange efficiency. This is going to be super important for oxygenation of our patients, and this is going to tell us how well that oxygen is going from the patient's lung to the patient's blood. Also, exercise response. PFTs are a great insight as to how well the lungs respond to physical activity. So, for our COPD patients, for example, they might be entered into a pulmonary rehab where they're doing a bunch of exercises that they're not used to doing. Over time, we hope to see improved PFTs from that. So, who gets a PFT? Patients who are suspect for a restrictive or obstructive disorder, or patients who have these disorders. You can see anything from asthma patients to emphysema patients, chronic bronchitis, things like that. This can be really useful for monitoring that disease process, diagnosing that disease, and determining if there's any sort of reversibility. We do something called bronchoprovocation to see if a patient's airway is reversible. And also, a PFT can help us develop the proper treatment plan. As I said before, not every patient is the same. So, PFT can give us a good insight as to what course of action that specific patient needs. Our asthma patients get PFTs. This is going to monitor their disease progression and treatment, as well as our COPD patients. Stem cell transplant in cancer patients. A PFT is going to be really good for evaluating and monitoring their lung health following a procedure. When I did my PFT rotation at Centennial, I actually got to sit in on a PFT of a stem cell transplant patient whose body was not receptive to the transplant, the stem cells that were transplanted to her. And unfortunately, her PFT was showing a lot of restrictiveness as a response to that. For pre-op patients, again, obtaining that lung health data, and that can look very different depending on the health of the patient and what that patient is actually getting surgery for. Main components for interpretation. We have our slow vital capacity, our forced vital capacity, our forced expiratory volume in 1 second, also known as our FEV1, and then our forced vital capacity, forced expiratory volume in 1 second, also known as our FEV 1%. And I'm going to dive a little bit more into each of these. So our slow vital capacity is a measurement of all of the amount of air that a person can slowly exhale from their lungs after a full exhalation. So this is the maximum amount of air that a person can slowly exhale out after they've had a full inhalation in. Slow vital capacity can assess our lung volumes and our TLC as well as our residual lung volumes. A decreased slow vital capacity could indicate a restrictive lung disease, and the difference between an SVC and an FVC can indicate things like COPD, emphysema. This is a reliable measurement of lung function in patients with neuromuscular disorders as well, which I find very interesting because I would say of most of these values that we're getting from PFTs, this one here is the least patient effort oriented. So it really does give us a true measurement of lung function in our neuromuscular disorder patients, as opposed to the tests that require a little bit more physical effort. So a forced vital capacity, also known as an FVC, measures the total amount of air that a person can exhale forcibly and rapidly after a deep breath. That's how I remember the difference between slow vital capacity and forced vital capacity. It's really in the name. So we have slow after that deep breath out, and then we have the forced out after the deep breath in. So forced vital capacity. This can help detect restrictive lung diseases if our FVC is reduced. This could also indicate possible obstruction if our FVC is normal or slightly increased. Predicted normal values are based on a patient's age, sex, height, and ethnicity. So not every patient is the same, again, but even from our baseline, not every patient is compared the same. So as you can see, just talking about our SVC and our FVC, you can kind of already start to tell that you need all of these different values together to see the overall picture of a patient. You can't just rely on one specific value. You've got to look at the whole picture. So our forced expiratory volume in 1 second, also known as FEV1, is the amount of air that a person can forcibly exhale in the first 1 second. That is fast, okay? The first second of the FEC remover. So this tells us that it's time dependent, has to be in that first second. And it's also effort dependent. The patient has to comprehend what you're saying, and they also have to physically put in the effort to accomplish that forcible exhale in that first 1 second. Something that I didn't realize would be an issue until I went to one of my PFT rotations is that if you have a patient and there is a language barrier, this is going to be really difficult to achieve unless you have an interpreter in the room doing it for you. You cannot just rely on things like Google Translate. This is also a primary indicator of airflow obstruction, and it can help determine the severity of disease, which we will talk about here in the next couple of slides. And it's going to monitor our disease progression and our treatment response. If we are doing a post bronchodilator treatment. So if we did a pre and a post bronchodilator treatment and we see a significant increase in our FEV1, this is going to suggest a reversible airway. So our FEV 1% or our forced vital capacity, forced expiratory volume in 1 second. This is going to represent the portion of total air expelled during that FVC test that is exhaled in the first second. And this ratio is used to diagnose and differentiate restrictive and obstructive diseases. So again, like I said before, we cannot just rely on one value in particular to give us a diagnosis. We have to look at the entire picture. And that is the end for this PowerPoint.